Welcome. Thanks for joining us today as we review the topic of anal emergencies. It is a subject we believe is of great importance since at some point in your training or practice, you'll be called upon to diagnose and/or manage one of these conditions. These are the conditions we'll be addressing today. It is not a complete list, but we feel it represents anal disorders commonly seen by general and colorectal surgeons needing immediate attention. By the end of this presentation, we hope you'll be able to quickly recognize presenting symptoms and key physical findings, in addition to knowing how to manage these conditions well. Let's start off with hemorrhoids. Patients typically present with a history of constipation and will describe either noticing blood on the toilet paper when they wipe or fill in the toilet bowl. Although hemorrhoids are very common causes of lower GI bleed, depending on the patient's age, family history, and associated symptoms, one should always have a strong suspicion for possible underlying colorectal cancer and make sure to rule it out. To understand how we classify and address different hemorrhoidal emergencies, one has to have an appreciation for the underlying anatomy. For a detailed review of the anorectal anatomy, please refer to the video on this subject available on the ASCRS website. Briefly, the anal canal is approximately 2.5 to 4 centimeters in length. Within it are prominent anal mucosa known as anal cushions, which are formed from loose connective tissue, smooth muscle, and a vascular plexus. The vascular plexus is formed by direct arteriovenous communication between the terminal branches of superior, middle, or inferior rectal arteries and their corresponding veins. The hemorrhoidal cushions are important for achieving complete fecal continence since the anal sphincters alone cannot fully close the anal canal lumen. Hemorrhoids are such an important part of our GI function, and we all have them. They are an issue though and draw our attention when they become symptomatic. Several studies have been done to try and understand why some hemorrhoids act out. The figure to the right of the screen goes over some of the underlying mechanisms, including a loss of fixation, increased venous hypertension, and redundancy in the rectal tissue, all compounded by the effect of constipation and straining. External hemorrhoids represent distended vascular tissue in the anal canal, distal to the dentate line. They are covered by anoderm and perianal skin richly innervated with somatic pain fibers. Diseases affecting the external hemorrhoids can be extremely painful. A sudden thrombosis can form that can lead to substantial swelling and sometimes a break in the overlying skin, resulting in bleeding. If not addressed, the thrombosis is typically slowly absorbed by the body over several weeks. As depicted in this graph, acutely swollen and tender thrombosed external hemorrhoids can be surgically excised if they present within 2 to 3 days of onset. After that time, any procedure typically worsens the symptoms and extends the pain curve. To appropriately manage and avoid early recurrence, it is important that one completely excise and evacuate the underlying clot instead of just lancing the skin superficially. Internal hemorrhoids are found above the dentate line and typically present with bleeding rather than pain. They are classified into 4 grades as shown in the figure. Internal hemorrhoids that have prolapsed and become strangulated, that is grade 4, are an emergency and warrant surgical treatment in an operating room ideally. Patients with strangulated internal hemorrhoids will present with pain due to the obstructed venous flow. It should not be confused with a thrombosed external hemorrhoid, given the associated pain symptoms. It is important that the patient is evaluated for any systemic signs of infection or local sepsis. An excessional hemorrhoidectomy is performed and the incision either closed or left open, depending on preference. If multiple hemorrhoidal columns are excised, it is important that skin and mucosa bridges are left in between to avoid anal stenosis, which is one of the more common postoperative complications related to the procedure. Now let's switch to discussing necrotizing soft tissue infections. This is an umbrella diagnosis for necrotizing forms of fasciitis, myositis, and cellulitis. When there is fulminant tissue destruction involving the perineal, genital, or perianal regions, it is frequently called Fournier's gangrene. The table on the left shows the common risk factors for development of Fournier's. I think what is striking is that up to 10% of folks who present with Fournier's have none of the traditional risk factors we have been taught to associate with the disease. This calls for a high level of suspicion. The table on the right reviews infections, other disease states, or procedures that can predispose a person to develop Fournier's. Patients typically present with the following symptoms and exam findings. As you can tell, some of the most common presenting symptoms are swelling, pain, and erythema. Most folks are taught to look out for bullae, crepitus, and skin necrosis, but you can see that that happens usually in less than 1/3 of patients. And so again, the pain and swelling and erythema are going to be your more common presentations. The CT scan here shows air in the subcutaneous tissue and muscle. This finding can sometimes be picked up also on X-ray depending on the degree of infection. Successful management relies heavily on early detection and a multi-pronged, multidisciplinary approach. A good history and physical exam should be the first things to raise and alert and are enough to start broad-spectrum antibiotics plus resuscitation as indicated while further workup is underway. Wide surgical excision and debridement down to healthy tissue should be pursued as quickly as possible with plans to return to the OR within 24 hours for wound assessment and further debridement as needed. To maintain wound cleanliness and avoid constant stool contamination, a diverting ostomy is usually needed and can be done at the time of the initial surgery or later on, depending on how stable the patient is. As part of the multidisciplinary team approach, many of these patients will require wound care nurses, physical and occupational therapy, and nutritionists during the hospital course. Involving plastics or other subspecialty surgeons such as urology might be necessary and important for planning reconstruction of surgical defects that can sometimes be quite morbid but required to completely eliminate the infection.
While many patients experience a small amount of bleeding or blood-tinged drainage, spontaneous rectal bleeding can be related to a number of anorectal pathologies. While most bleeding is low volume and self-limited, even amongst patients who present to the emergency department, a careful history and evaluation is key, as true anorectal hemorrhage can occur without previous surgery. Thankfully, hemodynamically significant bleeding from anorectal pathology is rare. The most frequent causes are varices, hemorrhoids, tumors, radiation proctitis, and trauma. The management of anorectal trauma is discussed in another video in this series. While these pathologies also frequently present with more minor or chronic bleeding, very heavy or significant bleeding can occur, especially when combined with anticoagulation. Initial evaluation includes an assessment of the patient's hemodynamics, a careful problem-focused history, perineal and digital rectal examinations, and an assessment of anemia and coagulopathy. Just like postoperative hemorrhage, if packing is helpful, it can be initiated early in the evaluation process. Serial evaluations of the amount of blood, vital sign measurements, and laboratory values may also be helpful. Similar to other GI bleeding, the initial management includes resuscitation with blood products and the correction of any coagulopathy. However, the anal canal benefits from its relatively accessible location, and often pressure and packing can be used as part of the initial management strategy. The definitive management of spontaneous anorectal hemorrhage depends on the pathology. While hemorrhoids are in the anal canal, and at least in theory are only below the dentate line, varices differ in that they extend up into the rectum where they involve the systemic circulation. It can be very difficult to distinguish between the two, especially in the acute setting, and patients may have both, so history plays an important role in both diagnosing anorectal varices as well as evaluating the cause of bleeding. However, when dealing with varices, even more caution must be taken, given the associated coagulopathy that comes along with portal hypertension and the frequently more fragile tissues. While suturing may be an option, the suture may rip through vessels and cause even more significant bleeding. Sclerotherapy, therefore, may represent a better option. In addition, treating the underlying portal hypertension should be a key part of this, and TIPS is recommended on an urgent basis for any patient with hemorrhage related to anorectal varices. It is rare for hemorrhoids to have hemodynamically significant acute bleeding without anticoagulation. However, if it occurs, suture of the apex or hemorrhoidectomy may both be used successfully in this setting. Rectal and anal tumors can bleed, but rarely hemorrhage. More often, this tends to be an ongoing process and can cause transfusion dependence, but rarely acute life-threatening bleeding if not immediately addressed. Initial attempts to control bleeding from a tumor in a stable patient may include things like palliative radiation, diversion, and topical hemostatic agents. Resection may ultimately be required even for palliation if the patient cannot successfully be treated with one of these other measures and remains transfusion dependent. Similarly, patients treated for other malignancies with pelvic radiation may experience bleeding, and it can be quite significant. The nature of the bleeding is similar to tumors, meaning it can be acute and ongoing bleeding, but not a life-threatening hemorrhage if it is not definitively addressed over the course of several hours. Formalin fixation is a good, low-risk first option for bleeding related to radiation. Argon beam coagulation may also be used, particularly if there is a targetable area or areas. For more mild bleeding, other topical agents such as steroids may be useful once the initial anemia and hemodynamic changes are addressed. In a situation of true hemorrhage, APR has been described for this etiology.
Rectal prolapse generally results from pudendal neuropathy or anatomic abnormalities, such as pelvic floor and anal sphincter laxity, a deep cul-de-sac, sigmoid redundancy, or a lead point mass. Urgent surgical intervention is warranted in the setting of irreducible rectal prolapse with tissue compromise, that is, incarceration and strangulation, both unusual entities. Patients present with a tissue bulge emerging from their anus and complain of perineal pain or sensations of incomplete evacuation. Physical exam will reveal irreducible, full-thickness concentric rings of rectal mucosa with or without tissue congestion, ulceration, or necrosis. Tissue sloughing and bleeding may also be present. It is also prudent to perform an abdominal exam to evaluate for signs of peritonitis. This can be an ominous sign that the ischemic process has extended beyond the perineum and involves intraperitoneal rectum and colon. An operation for symptomatic rectal prolapse is not always needed. Non-surgical reduction techniques with topical granulated sugar or cold witch hazel applied to the prolapse, paired with old-fashioned milking and patience, is often fruitful. However, definitive surgical treatment is indicated since failing conservative measures with signs of compromise. The approach is highly variable and includes multiple abdominal and perineal options. In the setting of incarceration or strangulation, urgent surgical correction is warranted. A perineal proctosigmoidectomy with coloanal anastomosis or Altmaier procedure is most common. This can be performed with or without an upstream fecal diversion. It is very important to fully inspect the upstream colon for extension of the ischemic process. This can be performed via the perineum if mobilization and visualization are adequate. If not, inspection of the peritoneal cavity via an abdominal approach, such as a diagnostic laparoscopy, is warranted. By far, the most common category of rectal foreign body etiology is voluntary insertion for sexual stimulation. However, it is important to recognize other etiologies such as involuntary trauma in the form of sexual abuse or voluntary body packing for illicit activities. Patients commonly present in a delayed fashion secondary to social stigma or embarrassment. It is critical to obtain an appropriate history using a non-judgmental approach. Symptoms can range from abdominal pain, constipation, and rectal bleeding. Findings may reveal perineal trauma. An object may or may not be palpated in the rectum depending on the depth and the patient's ability to tolerate a rectal exam. A pelvic X-ray can be used to localize and characterize the object. It can also assess for pneumoperitoneum. It is important to remember that patients can still present with rectal trauma even if the object had been previously removed. Peritonitis can be an ominous sign of a peritoneal rectum or colon perforation requiring emergent surgical intervention. The treatment approach depends on the presence or absence of a suspected or confirmed perforation. Transanal extraction at the bedside or in the operating room can be attempted. Use of a balloon catheter, endoscopic snare, or forceps can assist in retrieval. If the object has migrated above the rectum, a combination abdominal approach with laparoscopy to milk the object distally can be useful. Post-extraction, it is paramount to inspect the rectosigmoid mucosa to investigate for luminal trauma. In the presence of a perforation, an abdominal approach is warranted. Depending on the damage, a repair or resection must be completed. Based on the surgeon's skill set and the stability of the patient, this can be accomplished via laparoscopy or laparotomy. In conclusion, anal emergencies present in many shapes and forms. It is critical to obtain a detailed history and perform a diligent physical exam. Surgery is not always indicated, but a heightened index of suspicion is necessary to avoid further emergent consequences. Thank you for listening to our ASCRS Anal Emergencies Bootcamp video.